The common things about the two topics today, it is a form of vasculitis. We will deal with vasculitis in details in later classes. These are not exactly categorized in the box of vasculitis, so these two have to be discussed separately. Okay, so first of all, Kawasaki disease. A brief history: Kawasaki disease was first discovered in Japan. In the entire world, the major bulk of this disease is found in Japan. The major management strategies, the discovery of pathogenesis, the different etiologies, the different clinical forms, all of them first emerged from Japanese studies. The Japanese are the people who are most affected by this disease, and all this research regarding Kawasaki disease first was started from their end. So starting with Kawasaki disease. Before this nomenclature, Kawasaki, there is a physician called Mr. Kawasaki, and to the best of my knowledge, he is still alive. This disease is named after that physician. So what is Kawasaki disease? Earlier, it used to be known as mucocutaneous lymph node syndrome and infantile polyarteritis nodosa. The nomenclature is such so that it displays majority of the clinical features. Now, what is it actually? It is a systemic inflammatory disorder manifesting as medium vessel vasculitis with predilection for coronary arteries. So, whenever you deal with Kawasaki disease, there is a vasculitis, and the dreaded complication of Kawasaki disease is the coronary artery involvement, which can in later life can lead up to different cardiovascular disorders. See, it is the involvement is about 20 to 25%. So, this is a huge chunk. Okay, etiology, there is no specific etiology still discovered. The grossly you can divide it into infectious triggers or genetic triggers. There are many genetic triggers, the most important being this one, the polymorphism in ITP-KC gene. This is enough for Kawasaki to remember, the genetic one. And infectious triggers, any infectious trigger in the world can lead into Kawasaki disease. Any infectious, it can be bacterial, viral, fungal, any kind of infection can trigger Kawasaki disease. Now, the epidemiology. See, the worldwide it is seen mostly in Japan, but it is increasingly now being seen also in India and other Southeast Asian countries. You see, in India, it is not exactly a standardized incidence, so 10 to 20 per 1 lakh under 5 children, and the most affected are the one below 1 year. You see, it is seen 80% below 5 years of age. But across the pediatric age group, it can be seen in all pediatric age groups, but mostly under 5 and more below 1 year of age, the infants. Okay, so what is the pathology? So it is, as I said, it is a vasculitis of the medium-sized vessels. Okay, there are 3 phases of this disease pathogenesis. 3 phases. One is the acute phase that occurs within the first few weeks. One is the second phase that develops over years, weeks to years, and third is the actual chronic form that goes around for the rest of the lifetime. What happens? So first there is the necrotizing arteritis. As the name suggests, arteritis means arteries and inflammations. What kind of inflammation? The necrosis occurs. In the vessel walls, there happens necrosis. The first phase, it is carried out by the neutrophils, the neutrophilic necrotizing arteritis. The second phase is carried out by the other cells, the plasma cells, lymphocytes and eosinophils. And the third part that persists for a long period of time, maybe even into the adult life, is carried out by the myofibroblasts. What does myofibroblasts does? Myofibroblasts, as the name says, fibroblast is the cells that do fibrosis. So the chronicity is marked by the presence of myofibroblasts in the muscle layer of vessels. Now this is a brief pictorial depiction of the coronary arteries pathology. You see, first there are all the 3 layers of the vessels are affected. All the 3 layers. What happens? There is a distortion of the architecture of the vessel walls, all the 3 walls. Then there occurs, first there will occur a saccular aneurysm. Then there will occur a fusiform aneurysm. What is saccular and what is fusiform? Saccular aneurysm and fusiform aneurysm? The saccular is what? when it starts from one side of the vessel, and fusiform is it starts from all, the entire perimeter of the vessel is informed. Aneurysm means is basically it means in বোধা বাংলায় যাকে বলে dilatation, মানে ভেসেল গুলো ফুলে গেছে, okay. So first step is the dilatation, first saccular and then fusiform. So over the course of the disease, as the aneurysm grows on, the myofibroblast will come into action, and what will they do? They will do fibrosis. From fibrosis they will diminish the diameter of the vessels, and when the diameter is diminished, what is the virtuous triad? Then the virtuous triad come into action. So there will be formation of thrombosis, and as the chronicity goes on, thrombosis in later adult life may lead into myocardial infarction. At present it is being increasingly recognized that there are many cases of myocardial infarction. What is the common age group of myocardial infarction? Medicine hoye geche common age group. What age group do we find myocardial infarction commonly? Aged old group, na 50, 60, beyond 70. But it is now being recognized that there are younger age group people are also being affected in myocardial infarction. It has been studied for a long time, and it is now being found out that some of those young aged myocardial infarction may have their origin in their childhood, one of the major reasons being the Kawasaki disease. There may be in some point in their childhood or in adolescence they might have been affected by Kawasaki disease, which now is presenting with the cardiovascular disorders, myocardial infarction, or any form of acute coronary syndromes. Now the clinical features. Kawasaki disease is a clinical diagnosis, okay, and the most important clinical feature of Kawasaki is fever. If you have to ask one clinical feature of Kawasaki, and I will ask you tell me one clinical feature, and I will give you the pass marks, that is the fever. What is the most important feature? It is the fever. Fever, it is generally standardized duration of fever is 5 days. Any children, if you find a children of duration of 5 days of fever, no matter how likely the possible causes, other etiologies being possible causes, it may be infectious or any other cause, in any children with 5 days of fever, always rule out Kawasaki disease. No matter it is the least likely diagnosis, whatever it is, whenever you see patients of whenever you see any children of fever duration of 5 days, rule out Kawasaki disease. Remember this point today, and take this point today and remember it for your rest of the life. Any children with 5 days of fever, Kawasaki disease has to be routinely ruled out. It's not it's not any optional. You have to routinely rule out. You have to routinely consider Kawasaki disease. That much is the incidence going up in Southeast Asian. So what are the features? As I said, 5 days of fever. And what are the other features? As the name suggested earlier, the mucocutaneous syndrome. What we can see? We can see bilateral bulbar conjunctival injection without exudate. So non-exudative conjunctivitis. Here it is mentioned bilateral, but when you see the patient for the first time, you may not find bilateral, you may find unilateral conjunctivitis, but that surely has to be non-exudative. Non-exudative meaning it is non-infective in origin. So for important first is conjunctivitis, unilateral or bilateral. If you are given a question to answer, you will write bilateral, but keep it in mind, unilateral can be present in Kawasaki in the initial features. Then the changes in the oropharyngeal mucosa. What can happen? The most commonly found is the injected lips. Injected means congested lips. They can be injected lips, swollen lips, cracked lips, ঠোঁট ফাটা যেটাকে বলে, খুব বাজে ভাবে ঠোঁট ফাটলে যেরকম দেখতে হয় ওইরকম হবে. We have the pictures there. And then the changes in the peripheral extremities. Peripheral extremities, upper limb or lower limb. What can occur? There can occur edema. Starting with edema, there can occur the erythema, edema, and the most important part, the not seen commonly in first week, that is the periungual desquamation. What is periungual? Is around the nail folds. Okay, you will typically see after commonly after 1 week, they will have desquamation of the skin around the nail fold, both in upper limbs and the lower limbs. Next we have the polymorphous rash. Okay, this is the rash which is polymorphous rash. It is a very non-specific, but it can be present in the first week of the disease. And the cervical lymphadenopathy, about 1.5 centimeter. One catch is there, cervical lymphadenopathy, which is not given in this slide. It is usually first we see is a unilateral cervical lymphadenopathy. The majority books in pediatrics says it is unilateral cervical lymphadenopathy. So note this down when you write in exams or when you are asked, mention the unilateral cervical lymphadenopathy, usually unilateral. Okay, the size is about 1.5 centimeter, but around 1 centimeter we can also recognize for it to be Kawasaki. Okay, this is the, if you find the fever for 5 days and at least 4 features, it is Kawasaki disease. In a way, it is also called complete Kawasaki disease. Now, why there is complete and incomplete? Will come. See, incomplete Kawasaki disease, there are certain entities of Kawasaki disease which may not have all the clinical features. Okay, you may have fever for 5 days and you may only have 2 to 3 or even 1 feature. In that case, if you have strong clinical suspicion, what are you going to do? So we will follow this chart. I said complete Kawasaki disease is completely a clinical diagnosis. But when you do not find all the clinical features required for the diagnosis, we may have to depend on some lab features. So first of all, the CRP and ESR. Remember, in every rheumatological disorder, what you always first try to look at is the inflammatory marker. The two common inflammatory markers, CRP and ESR. So their CRP and ESR. If CRP and ESR are elevated, so your suspicion is based okay. Then we will have to find 3 out of those laboratory findings. What are they? Anemia for age. There is a chart for anemia for different age groups. So anemia for age, platelet count, thrombocytosis typically more than 4.5 lakhs. Albumin, hypoalbuminemia less than 3 gram per DL. Elevated ALT. You can find both ALT and AST elevated, but common practice is to see at ALT. And the WBC count 15,000, leukocytosis and urinary leukocytosis. This is important. You will get to see a lot of such children who will come with high grade fever, very toxic child. প্রথম দেখেই মনে হবে খুবই খারাপ বাচ্চা, very sick looking child. They will have high grade fever for 6 to 7 days, and some physicians somewhere will do a certain urinary and they will present with 15 to 20 WBC per hour, WBC per HPF. And what other thing they do? Urinary and urine CS. They will typically have a negative urine CS, and such urinary leukocytosis. So this is actually called pyuria. When you find leukocytes in urine, it is pyuria, but that is sterile, that is not giving any growth. So first thing, what is the first thing that will come to your mind? There must be some lab mistake. That's why I'm not getting the urinary culture. You will repeat the urinary culture and you will again find there are plenty of WBCs, plenty of pus cells, but there is no growth. This is what is called sterile pyuria. So sterile pyuria in a toxic child in a fever with 7 to 8 days, always rule out Kawasaki disease, because this is an important lab feature of incomplete Kawasaki disease. So you see, so 3 out of those lab feature, again repeating, anemia for age, platelet count more than 4.5 lakhs, hypoalbuminemia, elevated ALT, WBC count more than 15,000, and urine leukocyte at least 10. Even if you do not find all the lab features, if you find one positive echocardiogram of the heart and a positive echocardiogram finding that is not given, there is a perivascular brightness in echocardiography around the coronary arteries. That is not given there. When you do echocardiography, when you look at the coronary arteries, there will be perivascular brightness. The circumferential area of the coronary arteries will look abnormally bright. That is the echo feature of Kawasaki disease around the coronary arteries. If you find only that finding along with increased inflammatory markers and the fever for 7 to 8 days, that is Kawasaki disease. Now why do we have to consider complete and incomplete? Because it has been observed that if we monotonously follow this criteria of complete Kawasaki disease, many patients are being missed, and those patients are landing up in very complicated conditions which are not being recovered at the proper time. So that's why this incomplete Kawasaki disease, this criteria was formed. Okay, complete and incomplete, clear? So this is important, but beyond this, if you don't understand, we cannot progress. Any problem then complete and incomplete? Incomplete is lab based, complete is completely clinical criteria. Now other features, these are non-specific. So first is irritable. Among the minor features, irritability is most common. There is no children of Kawasaki disease in the entire world who is not irritable. A very irritable child, fever, irritability, fever itself causes irritability, but these kind of patients of Kawasaki disease, they will be overtly irritable. And one common minor symptoms is GI symptoms. This is also non-specific, vomiting, diarrhea, abdominal pain. Some may present with commonly with ARI, cough, rhinorrhea, and aseptic meningitis, hydrops of gallbladder. These are non-specific. One important is the BCG scar reactivation. Some will have 7 days of fever and reactivation of BCG scar, nothing. Okay. Now we'll see some pictures now. This is the polymorphous rash. You see, this is you can see this kind of rash in many diseases, very non-specific. This is one patient of mine, and this is the important periangual desquamation. ওই চামড়া উঠে গেছে বুঝতে পারছো সবাই, নীল ফোল্ডের চারিদিকে, তো পরে জুম করলে বুঝতে ওই থাম্বের চামড়া উঠে গেছে, গ্রেড 2 এর চামড়া উঠে গেছে. This is typical periangual desquamation, usually seen after 1 week. Again another picture, periangual desquamation. Again this is the edema of hands. Now this is important, strawberry tongue and conjunctivitis. এটা hemorrhage নয়, conjunctival hemorrhage নয়, এটা conjunctivitis. Strawberry tongue means it is a congested and reddening of tongue. Normal জিভগুলো দেখবে তার চেয়ে অনেক বেশি লাল মনে হবে. Okay, this is another, যে cracked lip injected, ঠোঁট ফাটার মতো যেটা দেখতে হয় অনেক বেশি খারাপ হবে. এখান থেকে বুঝতে পারবে কিনা জানি না, ওই দেখো ঠোঁট, এই দুটো বাচ্চারই ঠোঁটটা স্বাভাবিকের চেয়ে বেশি রেড মনে হচ্ছে. Okay, this is injected or cracked lips. BCG scar reactivation. Okay, this feature is not given in the clinical criteria. Perineal desquamation and perianal desquamation, these two features may work as the proxy of periangual desquamation. Usually if periangual desquamation takes time to appear, you may find this perineal and perianal desquamation. একটা কথা আছে না যে ওই শীতকাল এলে কি বসন্ত দূরে থাকে, এটা হচ্ছে ওই রকম. পেরিনিয়াল আর পেরিয়ানাল ডেসকুয়ামেশন যদি থাকে, রেস্ট অ্যাশিওর্ড এই আগের পেরিয়াঙ্গুয়াল ডেসকুয়ামেশন গুলো চলে আসবে. So this is used as a proxy. Okay, angiographic features. So what is the most dreaded complication of Kawasaki? It is the coronary artery involvement. What occurs in coronary arteries? It is the dilatation occurs. You see, এগুলো coronary artery, এগুলো angiographic features. এটা LED involvement, left anterior descending artery, ওটা right coronary artery. আর এদিকে যেটা দেখা যাচ্ছে, apart from coronary arteries, এখানে axillary artery involved আছে, common iliac artery involved আছে, popliteal involved আছে, subclavian involved আছে. Commonly coronary arteries. Apart from coronary arteries, in some cases also we can see axillary, other peripheral arteries like axillary, subclavian, popliteal, common iliac. Okay, this is another angiographic features. This is a giant aneurysm of left coronary artery. Now investigations, as we have already said, complete and incomplete. For complete Kawasaki, we do not need much investigations, but for incomplete, we need the lab investigations. এগুলো already বলে দিয়েছে, but one thing is important. KD is unlikely if ESR, CRP, platelet count are normal after 7 days of fever. Okay, so these inflammatory markers have to be elevated if it is Kawasaki. If it is a 7 days of fever without elevation of these inflammatory markers, it is less likely to be Kawasaki. So these inflammatory markers in fever more than 7 days have a good negative predictive value. What is negative predictive value? Comment pass করা আছে, কাকে বলে? Negative predictive value কাকে বলে? মানে বাংলাতে কি বলে? Negative predictive value কাকে বলে? একটু অন্য টপিক বলতে হয়, নাহলে মনোটোনাস হয়ে যাবে. মানে যেটা পেলে আমি বলতে পারি যে এই রোগটা নয়. Okay, what is specificity and sensitivity? What does negative predictive value signify? Specificity or sensitivity? What does negative predictive value? Specificity. Good. So this is a good negative predictive value, the normal ESR CRP in fever more than 7 days. Okay, ঠিক আছে। So differential diagnosis, রোগটা এমনই যে এই রোগটা দেখলে অনেক কিছু মনে হবে, 7 দিনের জ্বর, অনেক কিছু মাথায় আসে। কমনলি কি আসে? ভাইরাল ফিভারস। So adenovirus, scarlet fever, measles, cervical lymphadenitis due to any other cause. Okay, one thing, what is Rocky Mountain spotted fever? Which organism is the cause here? Rocky Mountain spotted fever, microbiology pass করা হয়ে গেছে। এক্সাম নাম বলতে কোন গ্রুপ অফ organisms? Rickettsia. Rocky Mountain spotted fever very commonly mistaken as Kawasaki, or Kawasaki mistaken as Rocky Mountain spotted fever. So these are some clues. Rocky Mountain এইরকমই polymorphous rash থাকে, ওখানে কিছু আলাদা ফিচার থাকে, যে ওখানে arthralgia থাকে, evanescent rash থাকে, এগুলো সব differentiating features, এগুলো আমি রিড আউট করছি না, এগুলো পরে দিয়ে দেবো, তোমরা দেখে নেবে। আচ্ছা, এইগুলো পরে পড়ানো হবে, systemic GIA, polyarteritis nodosa. Okay, and what other infections? CMV infections, hyper IgE syndrome, meningococcus, important. Meningococcus can present with similar rash like Kawasaki disease. Okay, so treatment. Khubi very simple treatment. Always remember two things. One is the IVIG. IVIG is the life-saving drug for Kawasaki disease. If you are ever asked what is the one treatment that must be given to Kawasaki, only one thing remember, this is IVIG. If you do not remember any other thing, remember IVIG has to be given. Okay, you diagnosed Kawasaki disease, যখনই ডায়াগনোসিস হলো সঙ্গে সঙ্গে, মানে এটা আমাদের যখন আমরা পিজিডিশিপ করতাম আমাদের বলা হতো, একবার একটা পুরনো এক্সপিরিয়েন্স ছিল যে কাওয়াসাকি ডিজিজ আমি ডায়াগনোস করেছি, প্রথম ডায়াগনোস করেছি, তো আমি খুবই এক্সাইটেড, স্যারকে ফোন করেছি, একে বলেছি ওকে বলেছি যে আজকে আমি কাওয়াসাকি ডিজিজ ডায়াগনোস করেছি। এই করতে গিয়ে 2-3 ঘন্টা আমার পেরিয়ে গেছে। পরের দিন সকালে যখন আমার স্যার এটা জানতে পারলেন, কোনো রেকগনিশন নয়, মানে রেকগনিশন লোকে এক্সপেক্ট করে যে ভালো ডিজিজ ডায়াগনোস করেছি, মানে উত্তম মধ্যম ঝাড়, তুমি 2-3 ঘন্টা ধরে বললে অ্যাটলিস্ট ট্রিটমেন্টটা চালাতে পারতে। সো নেভার দেরি করবে না, নেভার keep the patient untreated. The moment you diagnose Kawasaki disease, start infusing IVIG, because it has to be continued over 10 to 12 hours. Okay, the dose is not important for you, 2 gram per kg over 10 to 12 hours continuous infusion. What other managements? One is the aspirin and one is the steroid. Aspirin, so there are 2 doses of aspirin, the 2 roles of aspirin. One is the anti-platelet disease, anti-platelet dose, and one is the anti-inflammatory dose. First, on the initial phases of Kawasaki disease, we will administer aspirin at high doses, 30 to 50 milligram. Suppose a child is 10 kg is weight, so 50 per kg is 500. Adult patient এর 500 aspirin কাউকে দিতে দেখেছো? So it's a very high dose of aspirin, but it is required to decrease the inflammation of Kawasaki disease. So it has to be divided over 6 hourly, and it has to be continued up to afebrile phase of 48 hours at least. Then the aspirin will be decreased up to 3 to 5 milligram per kg. Okay, this is anti-platelet dose of aspirin. Okay, because I have mentioned the thrombosis may occur in Kawasaki disease. Okay, and some high risk group, high risk Kawasaki are those which has the coronary artery involvement. For those we will have to additionally administer methylprednisolone in this following doses. Okay, so remember 2 dose, most important is the IVIG, initial high dose of aspirin, then tapering of aspirin doses to antiplatelet dose. So IVIG, aspirin, and in high risk groups methylprednisolone. Okay, 3 drugs. Now one entity, IVIG-resistant KD, those Kawasaki disease which do not respond to IVIG. Response means there will be no fever. If the fever persists beyond administration of IVIG for 36 hours and beyond, that is called IVIG-resistant KD, Kawasaki disease. And there are the other options for treating IVIG-resistant KD. Infliximab, cyclosporin, anakinra. You just remember the names. You do not have to remember the mechanism of actions. Okay. Now, few words on multi-system inflammatory syndrome in children. এই টার্মটার নাম শুনেছো কোভিড পিরিয়ডে? MISC এই টার্মটা খুব চলতো বাজারে। Okay, after the emergence of COVID-19, especially in adult population and also seen in pediatrics, Kawasaki-like disease. Okay, So we have found there similar features like Kawasaki disease, but they were not exactly Kawasaki. They were mimickers of Kawasaki disease, and those group were under an umbrella were named multisystem inflammatory syndrome in children. Okay, and the most distinguishing features of MIAC and Kawasaki, there will be a temporal relation with COVID-19. And but the distinguishing other features will be greater degree of myocardial dysfunction. The children of MIAC will be sicker. Okay, there is a difference of Kawasaki and MIAC. Hemodynamically, MIAC patients will be bad from the very beginning. Okay, in simple words is this, and these are the different features. The MIAC will have hypotension, renal involvement, thrombocytopenia from the very beginning. Kawasaki may also have it, but not necessarily from the very beginning. And a few words on KD shock syndrome. Okay, this is a unique feature. In entire rheumatological disorders, all the rheumatological disorders, we generally find thrombocytosis because platelet is an inflammatory marker. In any rheumatological disorders, platelet either will be normal or will be elevated. But this is one such entity where you can find thrombocytopenia. So remember only this point, KD shock syndrome is the most lethal form of KD. KD shock syndrome in simpler word means Kawasaki disease presenting in shock. Okay, and what you can find is the pancytopenia, commonly thrombocytopenia. This is the only rheumatological disorder where you can find decreased platelet. All the diseases you will find normal platelet or increased platelet. Okay, complications, as you can see, myocarditis, heart failure, the adverse events related to giant coronary artery aneurysms, and one term here, hemophagocytic lymphohistiocytosis, macrophage activation syndrome. These two terms are for your level are used interchangeably. We will discuss it in the JIA classes. For time being, just remember the name. Okay, so this is the end of Kawasaki. We will move on to HSP. Any question from Kawasaki disease? So the clinical features, remember the fever for 5 days. Clinical features, fever in 4 out of 5. If you do not find all the clinical features, resort to the laboratory findings. At any point, Kawasaki disease cannot be missed. You take the help of lab or you do not take the help of lab. If you miss Kawasaki disease, invariably that child is going to succumb. Okay, so remember Kawasaki disease, do not forget it. A few history on Henoch-Schönlein Purpura. It is obvious that these are named after two physicians. Okay, this is a very unique combination of teacher and student. Can you tell me who was the teacher and who was the student? Henoch-Schönlein Purpura, two physicians, one teacher and one student. Just guess, ke student chilo, ke teacher chilo? Student Henoch. Or Schönlein hocche teacher. Ekdom thiki. Why am I calling it unique? Because before the discovery of HSP, the general trends in academia was to sudhu daktari noy. In general academia, the trend was if there is a duo of student and teacher, the name of the teacher used to come first and then the student. So Mr. Schönlein was very lenient on his student and he decided that no, his student must get the recognition first. Why did he say so? Because that among all the features of HSP, Mr. Schönlein discovered the purpuric part. He discovered that there is a non-vesicular, non-bullous purpura which is not associated with thrombocytopenia. Okay, there used to be entity ITP. He found that there is a non-bullous, non-vesicular entity not having thrombocytopenia. So he discovered the entity for the first time. Then his student Henoch, he discovered the other features which were arthralgia and arthritis, and one of the most complication is the pain abdomen, the GI involvement. So let's see. So HSP is the most common vasculitis of childhood. Remember this, in this class it will be asked in your NEET PG questions. Most common form of vasculitis in childhood. Okay, remember this is HSP. It is predominantly medium vessel vasculitis, small vessels can also be seen. Okay, this is also referred to as IgA vasculitis. Why IgA vasculitis? Because in this form of vasculitis there is deposition of IgA in the vessels. Okay, other name is IgA vasculitis. So commonly deposited in skin, you will find the dermal findings in skin, joints, GI tract and kidneys. Okay, epidemiology, 14 to 20 out of 1 lakh children per year. Males are more affected than females, and 90% of HSP are found in pediatric age group. Also, it can also be found in adult patients. Okay, there is a seasonal variability of the disease. It is found mostly in winter and autumn. Okay, pathology. This is just remember from this slide. Remember only one term: leukocytoclastic vasculitis. Okay, even in your sleep, you should be able to say this term, leukocytoclastic vasculitis. If you have to note only one thing, note leukocytoclastic vasculitis. What is leukocytoclastosis? Pathology question. সবাই পাস করেছে জন? leukocytoclastosis কাকে বলে? leukocytoclastic. আচ্ছা, এটা মানে হচ্ছে vasculitis done by the debris of different leukocytes, mainly the fragmented neutrophils. Okay, so include neutrophils and monocytes. These are actually the debris, the fragmented neutrophils. And what happens? Mainly the IgA deposition. We can also see deposition of C3 fibrin and IgM, but they are minor. Remember, deposition of IgA. Okay. So one more important thing, there is formation of immune complexes which get deposited along with IgA. What are the immune complexes? Are formed of immune complexes by anti-glycan antibodies. What is that? Anti-glycan antibody is the antibody against glucose moieties. Okay, any antibodies against any particular glucose moieties in a protein, if there is an antibody, that is called anti-glycan antibodies. In our body, the IgA we have in our body, that important structure of that IgA is the galactosyl residue. It has been found that in patients of HSP, the galactosyl residue in IgA is missing. So there forms of antibody which is called anti-glycan antibodies. These anti-glycan antibodies are formed against those galactosyl deficient IgA1. So those immune complexes get deposited in various vessels. Okay. And there are some infectious triggers like group A beta hemolytic streptococci, Staph aureus, mycoplasma and adenovirus. It can occur in family clusters. It is not typically there is a family history we find, but there can be family clusters associated with HLA-B34 and DRB1. Okay. Now the clinical feature. See, remember 3 features of HSP. One, the first that was invented, that was the purpura. Purpura is non-bullous and non-vesicular. Okay, first is purpura, triad of palpable purpura. The typical involvement of the purpura are over the dependent parts of the body, most commonly found on lower limbs, but it can also be found in upper limbs, and if in upper limbs, commonly in extensor surfaces and then the flexor surfaces. But remember, palpable purpura, non-bullous, non-vesicular, lower limbs, palpable purpura, along with arthralgia or arthritis and GI involvement, commonly manifesting in pain abdomen. A majority of the HSP patient we find in our clinical practice present with these two features most commonly. One is the palpable purpura and one is the pain abdomen. The pain abdomen, the GI involvement can be so severe that they can have lower GI hemorrhage. So few can present with intussusception. What is intussusception? অত টেকনিক্যাল টার্ম নয়, কি হয়? That remember this catch line, dream in dream is inception, intestine in intestine is intussusception. Okay, আমি অত গভীরে বলিনি, সুপারফিশিয়ালি বলেছি. Remember this inception part, you are seeing dream in dream, that is inception, intestine within intestine is intussusception. So skin lesions, it appears about 3 to 10 days, subcutaneous edema localized to dorsum of hands, feet, periorbital edema. Okay, hallmark of HSP is rash, palpable rash, palpable purpura. Okay, fine. Arthritis, arthralgia, GI manifestation, intussusception. The triad of HSP is palpable purpura, arthralgia, GI involvement, and arthralgia or arthritis. What is arthralgia? What is arthralgia? Arthralgia কাকে বলে? বাংলাতে কি বলে arthralgia? বাত অন্য জিনিস. Discomfort of joint. Okay, discomfort of joint is arthralgia. What is arthritis? What is arthritis? The definition of arthritis, remember, 2 out of 4 features. One is the swelling of joint, warmth of joint, সোয়েলিং ওয়ার্মথ রেস্ট্রিকশন অফ মুভমেন্ট, আরেকটা কি ছিল, সোয়েলিং ওয়ার্মথ, আরেকটা কি ছিল, পেইন, সরি, পেইন, সোয়েলিং, ওয়ার্মথ এন্ড রেস্ট্রিকশন অফ মুভমেন্ট, চারটের মধ্যে দুটো থাকলে তাকে আর্থ্রাইটিস বলে। ওকে, okay, so other involvement which is not commonly found, one is the CNS involvement, one is the renal involvement. Renal involvement, although it is not commonly found, but it is a very dreaded involvement. Okay, these are the typical rashes of HSP. Okay, so lower limb involvement, these are palpable, এখান থেকে palpable বুঝতে পারবে না, these are the flexor surfaces, commonly extensor, but we can also find the flexor surface involvement. Okay, now এগুলো বই থেকে নেওয়া, the typical dependent parts, the buttocks and the ankles. Lab finding, there is no specific lab finding of HSP. Okay, we can find, but platelet counts are typically normal. Majority of rheumatological disorders will have elevated platelet counts, but in HSP majority is normal, platelet count is normal. Okay, এটা একটা প্রশ্ন, IgA, the common conception is that if there is deposition of a certain molecule all over the body, there is supposed to be decreased level of that particular marker, but in this case IgA is typically elevated. The reasoning is that IgA is so much elevated that it has to it is going to deposit all over the body. Because it is elevated, that's why it is depositing, not the other way around. Okay, and USG is important in this case. Any HSP patient, means any patient presenting with palpable purpura and arthralgia, if he is presenting with pain abdomen, rule out intussusception. Always write USG in that patient to rule out intussusception. That patient may not have intussusception, but you have to write USG to rule out that disease. Okay, so it is a classification criteria. Only two things are required, that is a palpable purpura and any one feature among these. It can be abdominal pain, the GI involvement, arthritis or arthralgia, biopsy of affected tissue showing IgA deposition, and the renal involvement in the form of proteinuria at least 300 milligram over 24 hours. Okay, differential diagnosis, one important differential diagnosis, infantile acute hemorrhagic edema. This is how it looks like. Okay, it is a mimicker of HSP, looks similar to HSP, but commonly seen in age group of less than 2 years. Trunk is typically spared. Okay, so this one important, infantile acute hemorrhagic edema. And others, these are non-specific, PSGN, HUS, coagulopathy, SLE and urticaria. Management is supportive. If there is complicated HSP, if there is involvement of brain kidneys, you have to give pulse methylprednisolone, and the next we can go to IVIG plasma exchange. Pulse methylprednisolone is 30 to 50 milligram per kg for 3 days, and then we can go tapering doses of prednisolone. Okay, some steroid sparing agents, just remember the name, cyclophosphamide, azathioprine, mycophenolate, mofetil. These, just remember these names. Okay, complications it has a very good prognosis. Nothing bad happens from disease unless you have development of nephritis, which can later end up in end-stage renal disease. Okay.